thank you. Thanks for nicely summarising the multiple layers of complexity in that topic. I'll see if there's any questions or hands up immediately. I guess I'll kick off. So probably more related to like linezolid and amikacin that has stronger evidence with super therapeutic drug levels and toxicity. What's your experience in feasibility of accessing timely drug levels, particularly in non-metropolitan areas, getting results back in a clinically meaningful time?
So certainly in Queensland, aminoglycoside TDM is done every day of the week, and I think it's also done in North Queensland in Townsville. But our linezolid assay, our mycobacteria assays are only done as a batch run once a week. However, if it's urgent and you ring up the lab or email them, they'll do it any day of the week. So if you really had a critical linezolid concentration or level needed, then they would do that for you any day. So it is one of the issues is that to calibrate every time they turn the machine on for a mycobacterial assay, it takes them about $400. It takes about 2 hours of scientist time just to calibrate the assay every time they want to run it. So that's why they do a batch run. It tends to be on Thursday or Friday. So if you just miss that run, then you sort of have to wait another week for a result. So that can be time you take those results. If you take it on a Wednesday, and it takes a few days to get to Brisbane, and then you miss your Thursday, Friday run, then you got to wait till next week's run. So that can be a problem. But I think knowing when the lab are doing it and having some discussions with them, and they will do it if it's urgent. Generally, for mycobacterial disease, it's rarely that urgent. They can't wait a week. But that is an issue, Holly. I think it's a good point you've raised. Yeah, a patient with MDR, TB, meningitis in Townsville, they did TDM on the plasma, but also on the CSF because they had an ventricular draining, and they were able to do that the same day it was received because it was urgent. I see there's one question there.
I guess, was it Carrie? Would you like to go ahead?
Hey, Dr. Berg. My name is Carrie. I'm an infectious disease pharmacist at Cleveland Clinic in the United States. First, thank you for the presentation. I appreciate it. One quick question I had. So that was my first time seeing data for sulbactam durlobactam for any type of mycobacteria, which I think is super cool. I wanted to see, is it sulbactam durlobactam as the combination alone, or would it be in combination with another beta-lactam? Like, would you expect that combination to be efficacious?
In our study, we're going to use amoxicillin and ceftriaxone. If you look at those studies that were done, Carrie, so they were done out of Thomas Dix Group in New Jersey and the Bonomo lab as well. And so, so basically sulbactam has some abscessus activity and durlobactam does as well. But really where we're most excited about, at least on the in vitro data, is that it does lower the MICs quite markedly for everyday beta-lactams, including amoxicillin and ceftriaxone, which are available in oral forms as well. So for ISTX, who they're the company who makes sulbactam durlobactam, it's licensed for use just recently FDA for Acinetobacter infection in critical care. They've agreed to make the drug freely available for our study. So to answer your question, Carrie, will be paired with other beta-lactams, and we've chosen ceftriaxone and oral amoxicillin. That's talking another day why we've chosen those. But we think they might give it the best chance to shine.
All right, great. Thanks so much. I appreciate it. That's super cool to hear, just to see other uses outside of Acinetobacter. So I look forward to seeing them.
They're marketing it at $8,000 a day.
Yeah.
We're lucky we get mates rates for free. Yeah.
Absolutely. Thank you.
Can't see any other questions, and we are running a little bit over. So I'd like to thank Dr. Smith and Dr. Burke again for presenting today. And if you wouldn't mind completing the survey via the QR code, your feedback is very much appreciated. And if there's no other comments or questions, we might close the meeting there.
Thanks, Holly. Thanks, everyone.